so much, everybody, for joining our event today, which is on immigrant and refugee health and barriers to sexual health. My name is Tori. I'm the founder of Medical Herstory, which we'll tell you a bit more about in just a bit. And I'm so excited to be partnering today with CAWI, the Canadian Association of Women Immigrants, which Crystal will tell you about in just a second. And we'd like to start today with a land acknowledgement.
Thank you, Tori. So we'd like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. For myself, CAWI, and Medical Herstory, I would like to acknowledge that our organizations are based in Tiohtià:ke, or Montreal, which is situated on the traditional territory of the Kanien'kehá:ka, a place which has long served as a site of meeting and exchange amongst many First Nations, including the Kanien'kehá:ka of the Haudenosaunee Confederacy, Huron-Wendat, Abenaki, and Anishinaabe. We recognize and respect these groups as the traditional stewards of the lands and waters on which many of us are on today. We cannot begin to discuss patient advocacy, barriers to accessing care, or internalized stigma without recognizing the role that colonization, white supremacy, and medical racism play in the social structures which healthcare as an institution is situated in. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and consider how we are and can each, in our own way, try to move forward in a spirit of reconciliation and collaboration.
Thanks so much, Crystal. So today, this event aims to bring light to the unique barriers faced by immigrant and refugee populations when it comes to accessing sexual health services. Through showcasing the current work being done to support the sexual health and well-being of immigrant and refugee communities, and hearing the perspectives from our amazing panelists today, we hope to spark dialogue surrounding what approaches and considerations need to be taken to ensure positive sexual health outcomes for these populations. So a bit about Medical Herstory, for those of you who don't know. Medical Herstory is an international award-winning youth-led not-for-profit, and we're advancing gender health equity through storytelling, patient advocacy, medical education, and undoing stigma. We hold events like this, workshops, and publish stories with the goal of eliminating sexism, shame, and stigma from all health experiences. And today we're so excited to tell you more about our partners.
Hi everyone, so my name is Crystal, my pronouns are she, her, and I'm the outreach manager with the Canadian Advisory of Women Immigrants, or CAWI. So a bit about our organization. The Canadian Advisory of Women Immigrants is a registered and youth-led nonprofit organization in Canada, and we're a bunch of young people who are working to advance the empowerment of immigrant women in Canada. And we've created projects that are related to social support, social justice, the empowerment of women, mental health, and sexual health. And we're all very grateful for all of you being here this afternoon.
So if you've been to one of our storytelling sessions before, you know how these work, but if it's your first time, welcome. We're going to start off by introducing each panelist and asking them to share a bit about their story and experiences. We will then have a panel discussion with some questions that we think are important to be talking about today. And after that, we're going to have an open Q&A where you can all submit your questions and we'll have our panelists answer those. So to use the Q&A, what we're going to be doing is using Menti, because Medical Herstory loves to use the chat at our events to spark discussion. So someone will put this in the chat right now, but there'll be a link that you can click on and submit your questions at any point, and then we'll talk about those at the end of the event. If you're having any trouble with asking those questions, you can just message Crystal directly or myself if you need any help. And of course, you can put your name on those if you would like, or you can ask them anonymously as well. And just a little bit about Zoom housekeeping. Please keep yourself muted if not speaking today out of respect for all of our speakers. If you're comfortable, please keep your camera on. We love to see the lovely faces of our community members. Feel free to use the chat as much as you like. It's a great space to share your thoughts and reflections throughout these events. And if at any point you feel like you have feelings you'd like to address. If you're feeling upset by any of the content or anything's hitting a little too close to home, please know that Medical Herstory always takes a trauma-informed response, and we have active listeners present. So today, those are Anchal and Devin. They should have active listener next to their name, so you can contact them, and they're trained in supporting you throughout the event as well. And lastly, we just ask that you are respectful of everyone. Today, we are tuning in from places all over the world and coming from different backgrounds, but we want to ensure that this is a safe space for everyone. So we encourage people to be respectful of one another and also use gender inclusive language as much as possible. In terms of accessibility, closed captions are enabled. You can find them at the bottom of your screen with the CC symbol. You can access them at any time, and any other accessibility concerns, feel free to DM me throughout the event as well. And lastly, we just want to give a bit of a content warning to acknowledge that today's discussion may include topics around sexism, racism, ableism, medical trauma, mental health, and other sensitive subjects. So we recognize that these challenging topics may come up in today's discussion, and we are so grateful for our speakers for being vulnerable and sharing their knowledge and experience. But we also want to hold this space for you to practice self-care and take breaks as much as you need. And with that, I'm going to pass it over to Selma, our amazing co-host for today, to introduce our amazing speakers.
Awesome. Thanks so much, Tori. So I'd like to start off by thanking everyone for joining us today for this event. As Tori said, my name is Selma, and I am one of the project managers at our events team over here at Medical Herstory. I'm super excited to be introducing our amazing line of speakers to you all. So today we're going to start off with Dr. Huda Gonen. So Dr. Huda is an internationally trained physician who specializes in obstetrics and gynecology. Over the past 5 years, Dr. Huda has been working with the Newcomer Health Program as a coordinator at the Shore Center in Kitchener-Waterloo. In this position, she has helped develop, coordinate, and facilitate a variety of programs for newcomers to help provide education regarding reproductive rights and justice in Canada. In addition to this role, Dr. Huda acts as the advisory chair alongside the Region of Waterloo Immigration Partnership, where she works with various organizations to tackle racism. So with that, I'll pass it along to you, Dr. Huda, to tell us a bit about yourself and your work as it relates to immigrant and refugee health.
Hello, everybody. Thanks for inviting me to this event. I'm really happy to join you and listen for all stories. As I mentioned in my introduction, that I have been working at Shore Center for almost 5 years, and I used to run 3 programs. One for women, this is the one I started with, and one for men. I think everybody knows that Canada is one of the countries that support reproductive justice and reproductive rights for women. So those rights, unfortunately, are not applied in many countries, and we are receiving many immigrant and refugees who don't know about their rights and about how to access resources in the community. So in my main goal in my program, actually, I'm working as a member of the educational team at Shore Center. So I used to run these programs all over my community at Kitchener-Waterloo and at school. So as I said, I started with the women program, and then according to the participants, they asked me to develop a program for their girls, the youth girls. So I developed a program for moms and daughters to talk about sexual health and resolve those barriers between moms and daughters, especially youth girls during puberty, and how to help her and how to get support from her mom. It's part of educational to the mom, especially they are not familiar to talk about those topics sexual health, and they don't know how to open those topics with their children. So it was great to start this program. For 5 years now, I'm running the program, which is great, and the feedback is positive. And also at the same time, I used to run a program for men before COVID, and we stopped during COVID, unfortunately, because as I said before, I want to give the same information for both partners, for the women and the men at the same time, regarding the reproductive justice and reproductive rights. So they will be working together to take to make their own decision regarding pregnancy, regarding contraception, regarding having a child, and all that stuff. This is what my story at Shore Center, and I'm so proud to be part of our team at Shore Center. And also I worked with immigration partnership, our immigration partnership in the region of Waterloo, to eliminate racism and discrimination. Especially I'm working for almost 5 years, so I'm getting feedback from my participants regarding racism in healthcare system and barrier. And those barriers, unfortunately, it impacts the outcome, especially population growth in Canada rely mainly on immigrant and the refugee. And we have Syrian influx 5 years ago, and that's and Afghani maybe a couple of months ago, and now we are prepared to receive Ukrainian immigrants now. And that's why we have we are getting more diverse and more childbearing age for the women who needs support to access reproductive centers to make their own decision regarding contraception, regarding antenatal care, mental health, all that stuff. They are going through many challenges that they need our support. This is what I'm offering in my program. Support to newcomers, refugee or immigrant, or everybody in our community who needs our support. We are supporting them to access our resources and get what they need. At Shore Center, we are offering contraception, we are offering free condom. We are running all these programs all over the community, and we are working with different organizations in our community to support newcomers. And also I'm working with immigration partnership to develop a new system to report racism, report discrimination, especially in healthcare system. So this is my story.
Awesome. Thank you so much, Dr. Huda, for telling us about your journey. And I think it's really awesome to see how you identified kind of those gaps in service that you saw with all the different populations that you've worked with, and are really working in a very multifactorial way to kind of like fill those gaps. So yeah, thank you so much for sharing that. Awesome. Okay, so we will move on to our next speaker. So next up we have Natasha Lama, otherwise known as Lama. Oh, sorry. We'll share slides first. Getting a bit ahead of myself. Okay, fabulous. So yeah, Natasha is a Malaysian Indian sex positive advocate and educator, having a background in psychology and public health where she's specialized in sexual health. Natasha uses her platform to destigmatize STIs and celebrate conversations surrounding pleasure, sexuality, relationships, and bodies. Natasha is currently completing her Master's of Counseling and working towards her goal of becoming a sexologist in the future. So Natasha, I'll hand it off to you to say a few words about yourself.
Of course. Thank you so much, Salma. And thank you so much, Medical Herstory, for having me today. I feel very, very honored to be here around with like the rest of the speakers having such a amazing, rich background, which I can't wait to hear from them as well. So yeah, I am Natasha, but most people call me Lama, which is my last name. It's a little bit of a long story about it. But yeah, so feel free to call me either. I'm happy with either of them. I just like to begin also by acknowledging the traditional owners and custodians of the land that I'm on today, the people of the Kulin Nations, and I also pay respects to their elders past, present, and emerging as well. So yeah, a little bit about me. I was actually born and raised in Malaysia, and then I moved to Melbourne in Australia about almost 7 years ago now. So I've been in Australia for quite some time, and I think I've spent most of the chunk of my like young adulthood growing up here. So a lot of Australia does feel like home for me. When I go back to Malaysia, I feel like a little bit of a tourist. And I think, you know, when it comes to my perspective and what I bring to the speaker panel, you know, I only humbly bring my own personal lived experience. I don't have any direct experience with the refugee community, which I wish I did, because they are just so precious, and the way that Australia treats our refugee community is not the best, and I can definitely shed light on that. But yeah, I do bring my own experience as someone who has immigrated to Australia, and my experiences starting here as a young student. So I started here while I was doing my bachelor's, and you know, fresh 18, everything was new, everything was exciting, but also very, very scary to be in a new country by yourself. I was lucky I did have a small little bit of family here, but you know, it was nothing compared to what I had back home in Malaysia at that time. So yeah, as you know, I went along, it was definitely very interesting being in a country whose medical system is very, very different to that of Malaysia, which is where I grew up in. I think here, when it comes to going to the doctors, I definitely got a huge cultural shock in terms of how less judgmental they were of young people being sexually active, how more open they were in terms of, you know, discussing with you your options, and also that there was free medical healthcare here in certain places, and free sexual healthcare, which was not very common in Malaysia. And you know, here, if you were to get a medical practitioner being whether it was discriminatory, judgmental, racist towards you, that was more of a shock and like blasphemy, versus being in Malaysia, where going to a doctor, a gynecologist, like healthcare practitioner, and especially when it has to do with your sexual health, and them being a little bit judgy was seen as like, yeah, of course, what do you expect? It's Malaysia, which is really, really frustrating to me, honestly. So, you know, I guess a culmination of my experiences growing up pushed me to want to start my little Instagram page. It was just like a little lockdown project. And I had always, you know, wanted to talk about sexual health and just normalize conversations around pleasure, relationships, our bodies, especially growing up in a community where it was seen as a taboo. So yeah, and that's basically where I just talk about all things. I love destigmatizing STIs. I feel like STIs are very, very misunderstood and very, very demonized and feared, when yeah, you know, there's so much more that I wish we knew about them. And yeah, that's just basically me. I'm just someone that loves talking about sex positive things and just normalizing very, very normal sexual desires and expressions that we all experience as young people.
Fabulous. Thank you so much for sharing that, Natasha. And I think, yeah, your journey from coming from like Malaysia and then arriving in Australia, and just that big culture shock really resonates with a lot of immigrants who kind of, yeah, make that big journey. So fabulous. Before we head into Layla's introduction, I just wanted to kind of take note of the fact that Dr. Huda, I know that you have to leave a little bit early today just because it's Ramadan, we're fasting. So I know that you have to leave a bit early, and I just wanted to thank you for kind of speaking a bit about your story and your journey. But yeah, if you have to leave a little early, I believe Crystal will drop some information about the Shore Center in the chat below. So I encourage everybody to go check that out. Fabulous. Okay. Going into our last speaker. So we have Leila Hashimi. So Leila is a campaigner and communicator from London, where she works at Shape History, which is a social impact communications agency, on digital advocacy and communications projects. Currently, she is working with various digital and sexual health initiatives, including Love Sex Life. The Love Sex Life partnership was commissioned by various councils within South London to promote better sexual and reproductive health to residents of diverse heritage, with a specific focus on residents from Black, African, and Caribbean backgrounds. In 2020, Leila and colleagues from across the partnership conducted research to help shape the direction of sexual health and reproductive services and their communications to Black, Asian, and minority ethnic, otherwise known as BAME, communities in South London. Okay, so Leila, I will pass it along to you to tell everyone a bit about yourself.
Thanks, Salma, and thank you so much to Medical Herstory for having me today. It's such a kind of a pleasure and an honour to be with the amazing speakers and hear more about what you're kind of working on, especially with this being a really kind of global group. So a bit about me. I was born and raised in the UK, in London specifically, to immigrant parents. My mum's from Brazil and my dad was from Iran. London being a really kind of multicultural community and as a whole really diverse, kind of meant that kind of an interest in migrant and refugee rights kind of came quite naturally to me. My sort of background is in comms and communications and advocacy, so I'm not a sexual health expert per se, but over the last kind of 2 or 3 years, I've been kind of supporting an emergent sexual health partnership, as kind of mentioned by Salma, which was commissioned in 2020 to promote better sexual health to migrant and immigrant populations in 3 boroughs in South London that share quite similar kind of inequalities and barriers to good sexual health. And I guess for context, Brixton and Lambeth and the kind of surrounding boroughs have a really high kind of rates of HIV, of STIs, and lots of inequalities within that. And also there's a really high kind of number of Latin American communities, and in particular kind of Black African and Black Caribbean kind of residents. And there's a really kind of strong community there as well. So that's just a little bit of context kind of behind the partnership and the work that we've been doing. But I thought it would be good to maybe briefly chat through our 2020 research, and which I can sort of share the link to after I give a bit of a presentation. But just for context then, I guess like our service was commissioned really during the COVID, well, right at the beginning of the COVID-19 pandemic. So yeah, we had our first few meetings and then everything went off online. So we were tasked with commissioning some kind of local community research, but that all had to sort of shift in terms of methodology and everything. We had to go online and conduct interviews over the phone with more kind of like vulnerable service users, as well as putting together a large kind of type form survey and trying to sort of like push that as much as we could. So it was challenging, but really important to be able to kind of ground our communications in community research. Yeah, and as I mentioned, rates of kind of HIV and STIs are the highest in Lambeth, Southwark and Lewisham across kind of the UK. So, and that really does impact kind of Black and minority ethnic communities kind of the worst, and really they're sort of suffering the kind of the greatest burden with that. And while new HIV diagnosis rates are falling across England, they do remain the highest in Lambeth, Southwark and Lewisham, with 8,700 people testing positive. And within that, the highest kind of rates of late diagnoses do include women of Black African ethnicity in their 50s and 60s. And the purpose of conducting that research was really for us to be able to identify the current barriers or gaps in provision that Black African, Black Caribbean and other ethnic minority residents experience with regards to their sexual and reproductive health, as well as identifying solutions and opportunities. So all of that kind of information we've really used to create a service that can adequately kind of meet the needs of our residents and work really in collaboration with the local partners, community groups, as well as residents themselves. In terms of the kind of methodology, we were actually able to speak to 150 residents. 20% of them were from Black African ethnicity, and lots of other, a big mix in terms of that kind of sample size. So it sort of felt representative and made sure that we were kind of reaching the right people. And we found that the kind of proactive communication of that research back was really seen as crucial to strengthening relationships with the community, and kind of build the credibility of our service. I'll just quickly summarize the key findings, and then maybe in the Q&A, if you have any kind of follow-up questions, that's fine as well. So we found that there were kind of three key themes within the research, and firstly, really a lack of sort of safe spaces for residents to engage in their sexual health. So structural barriers, including housing, really were found to impact residents from seeking testing and treatment for STIs, from HIV, accessing contraception, and that really sort of emphasised the importance of looking beyond sexual health and solutions. We saw a kind of mixed preference for accessing sexual health services in formal and informal settings. And I think the COVID-19 pandemic really exacerbated the situation, particularly for like refugees and migrants. So we had kind of reports of COVID-19 kind of forcing refugees in particular, and LGBT kind of migrants as well, kind of back into the closet, and having to kind of hide that sort of situation from their families, and other kind of problematic kind of instances of the pandemic really kind of exacerbating existing inequalities. Stigma and shame were kind of big factors and big barriers to kind of sexual health outcomes, as well as kind of mainstream sexual health services kind of lacking culturally specific systems and support. So as a result of the research, we've been able to kind of create a really collaborative partnership, kind of comprised of Shape History, who are the kind of the comms partner, as well as Blueprint for All, who are a kind of community stakeholder group, kind of Black-led, and with really kind of strong links across the three boroughs. And we work in partnership with that organisation, and then two other kind of leading sexual health services, and one that's Black-led, called NAS, and the other, which is a young person service called Brook. So the four organisations work to promote and support other services with kind of training, events. So we've produced kind of webinars, we're collaborated with influencers and Black sexual health experts. And yes, also really pushed kind of communications campaigns on different topics within sexual and reproductive health over the last few years. And yeah, I think I'll stop there, but really looking forward to kind of continuing the conversation. And yeah, thanks again for having me here today.
Awesome. Thanks so much for sharing that, Layla. Yeah, I think the specificity of this type of research and having it be so community-based is so important for it to kind of come out with effective change, and to be able to engage with like stakeholders in the community and stuff when we're kind of applying those results is super important. Fabulous. Okay, so with that, we will now dive into our panel. So we've prepared a couple of questions beforehand that we'd love to get our speakers to answer, get some perspectives on. So starting off, we all know that gender health inequity is super pervasive in our medical system, but I'd love to go around and kind of just chat about what gender health inequity looks like for immigrant and refugee populations specifically. Dr. Huda, I see that you're still here with us. I know that you have to leave soon. I was wondering if I could get your perspective first before you head out.
Yeah, for sure. Yeah. Actually, I will talk about Shore Center. We are offering a positive environment for any sexual health. We have I will talk a little bit about our organization. We are offering contraception. We are offering insertion IUD. We are offering abortion clinic, and we have this our educational team. So I think we are offering a positive environment for sexual health, but still people, when they access other healthcare centers or any center, they are struggling with those challenges when they have what's called sometimes unconscious bias when they are accessing the center, the healthcare centers, and those things could impact the results. And some of them, sometimes I got a feedback they don't want to go again to that place. So we need to support our, reach out to and to different organizations to support our goals and support our our help to people. So this is the things I got a feedback from my participants actually. So I'm trying to help them, especially with language, because language is a big barrier also. And this is my message actually to healthcare professional, that they need to active listening to participants and be the leader to overcome these unconscious bias when participants reaching out asking for service. So this is the main things I'm working now on it in our community. Yeah.
Awesome. Thank you for that. Did our other two speakers have anything to say on that?
Yeah, I don't mind going next. I think in terms of on a UK level, we do have a public health system. We have the NHS, so that's most sexual health services are free to access, but austerity measures in the UK have really resulted in lots of cuts to public spending and sexual health provision services. And I think the COVID-19 pandemic really made that worse. And I think that for migrant and refugee women, they also kind of experience gender inequalities, which then end up being kind of compounded with other barriers. And on a kind of a local level, that looks like things like immigration status and housing, relating to kind of trauma faced back home, harmful practices like FGM, or so-called honor-based violence and stigma and shame relating to sexual health, and all of those kind of exacerbating some of those inequities. We have STI kind of inequalities and HIV as well, which I think is kind of felt at on like a national level, but in NSL we do see that kind of Black African women in particular kind of face particular inequalities. So you have, I think 36% of kind of the majority of new diagnoses of HIV are actually in fact now within the kind of heterosexual community. And I think a high proportion of that is now in older African women, and many of those only kind of finding out that they have HIV kind of at a very late stage, which is obviously problematic in terms of testing and treatment. There are, I think, migrant and refugee women also kind of face increased risks of kind of reproductive health inequalities. That's both from a kind of contraception perspective, but also thinking about kind of abortion rates. We have kind of concerning data at local levels showing that 8% of Lewisham women, for example, or 11% of Lambeth women kind of age under 19 having had an abortion, who also having had kind of an additional one during the same year. Yeah, there are a few kind of other things as well, which I think are kind of tied to sort of socioeconomic inequality. You have disproportionate numbers of HIV cases locally, which are kind of diagnosed in people living in the 40% most deprived areas, and that really does kind of impact migrant and refugee populations. And there are kind of estimated to be around 1,000 people living in LSL who are unaware that they're living with HIV. And I think I'm not sure if, so this is a kind of UK-based initiative, but I'd really recommend checking it out if you haven't heard of them, called Decolonizing Contraception, who talk a lot about kind of historic medical racism. And in the UK, there's a growing body of evidence which really kind of links the development of sexual and reproductive health medicine on kind of unethical medical research practices. And I think that does tend to have a strong impact on migrant and kind of refugee women, because the colonial past of public health then impacts, you know, how communities feel in terms of kind of engaging with healthcare professionals, and that really does have a legacy in diaspora communities. So I think that's something to bear in mind, as well as kind of what I mentioned sort of earlier with the COVID-19 pandemic exacerbating those inequalities and bringing things to light. So interestingly, we kind of saw that the pandemic seemed to kind of increase anxiety about underlying health conditions and a need for sexual health screening. So there were sorts of reports of people who, whilst there had been a kind of reduction in testing, there was an anecdotal increase in people sort of testing positive for HIV. So that's kind of, again, late diagnoses and a kind of a cause for concern. But yeah, I think a lot of the kind of the key inequalities that migrant and refugee women do tend to face in the UK are very much linked with kind of the immigration system, structural inequalities, and we can't really, it's important to sort of see it all in that kind of wider kind of political context, as well as some of the more, I suppose, kind of entrenched kind of cultural stigmas as well. Yeah, hopefully that was helpful.
Yeah, that was awesome. Thank you so much. Natasha, would you be able to kind of like comment a bit, I guess, on your personal experience kind of in the Australian healthcare system as an immigrant?
Yeah, absolutely. I think similar to the UK, Australia does have a public health system. So theirs is called Medicare here, but a lot of the time it's not accessible for people who aren't permanent residents or citizens here. So usually as a student, you know, you have to have a, based on your visa requirements, you have to have an overseas student health insurance. God, it's a mouthful. But yeah, you've got to have insurance, and you know, usually that insurance does give you access to services. But a lot of the time it can be quite overwhelming, and there's lots of jargon, you know, when it comes to understanding your insurance claim. And a lot of the time, students don't come from a background where English is their first language. A lot of the time that's already one barrier for them. So they don't really know what services they have access to, that also that they don't have to pay for. Because yeah, services without your insurance or under Medicare can be quite expensive out of pocket. Yeah, so for me, I think I was quite lucky in that where I was studying there, you know, the university was quite lovely in that they always like dispensed information quite often, you know, telling students that this is where you go for this, this is where you go for that. And we had a free sexual health clinic just up the road, about 10 minutes walk from the university. So that was really great, except because that was the only free one around, and the only free sexual health center that allowed you to be anonymous. So you don't really have to provide, you know, your you didn't really have to provide your like passport. You didn't really have to provide an address and things like that. It wasn't compulsory. You didn't have to. Most clinics, you have to do that when you're around here, and you also have to provide your like Medicare card or your insurance card. So I think in that way, that clinic, although there was only one, I wish there were more, but in that way, that clinic did make a lot of things more accessible for young students, or just young people like me that were just really like a bit afraid of accessing services, and you know, being afraid of things being on the system, being like, oh my God, everyone's gonna know that I'm going for this, going for that. So it was, you know, that one barrier was already removed by having those types of services. So yeah, for me in that way, it worked out. It was quite easy to access. Yeah, but I think in terms of the general student population in Australia, it can be really, really challenging because there is sometimes a language barrier. You know, Australia has such a diverse population of students that come from all over the world. And, you know, obviously during COVID, they saw a decrease of that because borders were closed and things like that. But alarmingly, because, you know, we were in a pandemic a lot of the time, because we were in lockdowns, Melbourne is the city notorious for lots and lots of lockdowns. So we've been through quite a number of months in lockdowns, and during a lot of that time, most people didn't get their regular sexual health checkups, and not because they didn't want to, perhaps because they didn't really see the need to, or they were afraid of going out because there was a pandemic, and we did have very, very high cases during the lockdown. So a lot of the time their sexual health was neglected, and because of that, now you're seeing a lot of like a higher reoccurrence of STIs that were previously sort of lower in terms of like their statistics. So yeah, it's really interesting. I can only give my perspective, and for me, I was quite fortunate that I was studying in an area where I had services that were accessible, but that's not the case for a lot of students.
Totally. Okay, yeah, thank you so much for sharing that. It seemed a lot like both what you and Layla were saying kind of like mirrored each other a bit, which is, yeah, kind of goes to show that this isn't kind of like an isolated incident. It's very like global and can probably be related to by a lot of immigrants and refugees. So our second question was about barriers, but you two both seem to touch a lot on what those different barriers kind of look like. So I'm going to move on to our third question. So looking at the role that kind of healthcare professionals play in immigrant and refugee health, what are some ways that you think healthcare providers can reduce the barriers that immigrants and refugees face when it comes to accessing quality healthcare?
Sure, yeah, I don't mind going first. So I think really thinking about reducing the barriers, it's about kind of looking beyond sexual health and really kind of recognizing the different health needs and barriers that that migrants and refugees do face when accessing support. And I think healthcare providers need to be cognizant of those kind of challenges, but also opportunities, and think about how to prioritize that as a kind of key aspect of their medical training and providing that kind of regular cultural competency training to clinicians. And I think in terms of access to services, it's about kind of giving options to people about locations of kind of mobile testing and where they can kind of pick up kind of test kits if that is their preference, in terms of not having necessarily to present within a clinic, and sort of having the availability as well of home testing kits located in local access points. And we found kind of through our research, but also just through feedback from service providers, that having those kind of points based in local community settings like churches, mosques, shopping centres, clubs, and things like that is also a really good way of ensuring that we are kind of reaching migrant and refugee populations with kind of testing and treatment at least. Obviously, kind of in-person clinic care is still really important, but isn't always appropriate depending on kind of that individual situation. I think also signposting and communications is really important. So thinking about kind of the availability of both in-person and digital services. We've really pushed kind of during the pandemic this online testing service called LSL, kind of Sexual Health London, but we use a kind of local link. So that's a website where anyone and everyone can order a free test kit, and that has really seen like an uptick during the pandemic. But I think then equally the availability of walk-in appointments is still important, as I kind of mentioned. I think a bit like something that we've done a lot of, especially as like the communications partners, is really thinking about how to diversify the health promotion as well. So I think that's something that services can sort of learn from. So if migrant women may not be presenting to clinics and services and GPs, I think those services can really consider how they can utilize things like WhatsApp, local social media groups, like community radio, and also kind of working closely with local faith leaders and influencers, which are all have been really kind of effective ways of reaching different individuals with sexual health information, guidance, and things like that. And I think really ensuring that that communication is culturally specific and sort of translated where it can be. So yeah, thinking about like what are the kind of most prevalent languages, and whether or not having translated resources can be useful, I think is a big one. For us as a service that's mainly kind of focused at kind of Black communities and Black residents, we tend to have a few key languages that some resources are translated to, but I think we're thinking about kind of more recent refugee and migrant kind of migration, or people arriving in Canada or the UK or Australia. I think that's going to be increasingly important, like interpreters and things like that. I think maybe the last thing I'd mention as well is the kind of importance of peer research. So like, I guess like research led by and for the community. We've been kind of collaborating with someone based in the UK called Zoch Noasu, whose thesis was basically him interviewing other Black men in London and really placing their voice at the centre of sexual health service development in the NHS. And his research has like really reinforced the value of documenting community intervention, so that mainstream services are able to then integrate that into sexual health services. And he found that within his research, for example, it was one of the first studies to do something similar. The majority of kind of Black male focused sexual health studies were all like US based and not really relevant necessarily to kind of the needs and experiences of Black men living in London. So ensuring that that kind of peer-led, community-led intervention is available and funded crucially has been, I think, a really key thing to come up for us. And I think, yeah, mainstream services could kind of learn a lot from some of these more like local interventions, and in terms of improving kind of service and access for migrant and refugees, obviously for women in particular.
Awesome. Yeah, I think you gave quite a lengthy list of like really actionable ways that healthcare providers can kind of bridge that gap a little bit. Awesome. Natasha, do you have anything to add on?
Absolutely not. Leah has put it spot on. I just want to mirror everything that she said, definitely thinking outside that just sexual health bubble, because cultural competency is so important. And yeah, diversifying health promotion, translating them to languages that are, prevalent within the communities around. Just spot on, Leila, everything you said.
Awesome. Okay, so that takes us to our last question. So I'd love to get both of your perspectives on what advice you would give to newcomers regarding patient advocacy, especially, I guess, within the sexual health realm.
Hi. So I think the main thing, because this is something that I personally haven't had so much experience in, particularly within our research, but I think the one recommendation that came through was, I guess, for anyone who is kind of concerned about any aspect of their sexual health service experience, that I guess tapping into any local advocate services can be supportive. So I think also having, I guess it's really important for services to provide anyone kind of presenting themselves to a clinic with the space to ask for any like reasonable adjustments to their healthcare. I think that's an important one as well. But I think maybe that's one that I maybe can defer to Natasha on. I
think, just speaking from my own experience, I think just when it comes to advocating for your patients, I guess what I would love to see practitioners do, I think, is just ask your patients more questions. What would they like to see when it comes to the care that they're given? And I think, the people that we are trying to get into these services are experts in their own lives, and they have a lot to offer to people that are trying to understand better. So I think it's really important in sort of putting yourself in the shoes of the expert. Of course you are medically, but I think they're the expert in terms of their life and what can we do as people trying to advocate for them to like better the services. So I think definitely putting them in the shoes of the expert. That's like the one thing that I could think about.
That's awesome. I think Tori already mentioned it in the chat, but that's kind of like one of medical history's like core values is like the patient is the expert in themselves and their experience. So yeah, okay, fabulous. So that brings us towards the end of our panel. I'd like to thank you both for your insightful and like thoughtful responses to all of our panel questions. With that, I will hand it off to my co-host Crystal, who will be facilitating the Q&A portion of our event.
Hi, so thank you so much for your talks. I thought they were really insightful. So I think the first question that we want to start off with today is, how do you think cultural barriers, taboos, or traditions might impact the doctor-patient relationship?
I can go first this time. I'm sure Leila has heaps to add as well. Yeah, that's, I think, a huge part of the like doctor and patient relationship. I think less about Australia, I mean, a little bit of Australia, but even more so about Malaysia, which is where I come from, because, you know, we do obviously also have a huge immigrant and refugee population, but I think when it comes to the cultural barriers between doctor and patient, a lot of the times when it comes to people who are in the, you know, sexual health field, so gynecologists, urologists, all types of doctors, GPs that see these patients, so much of their like cultural stigma against, you know, things to do with sexual health does come into play when they're treating patients. A lot of the time in Malaysia, you have young women having a really, really difficult time accessing contraception because, you know, you have doctors that are, first of all, young single women accessing contraception is very, very difficult because, you know, then they do experience judgment, stigma from doctors sometimes, even if it's not very blatantly obvious, it can be quite subtle, and it does make them feel quite uncomfortable during their appointments. You know, doctors can ask really invasive questions that are quite personal and not really relevant towards providing the patients the proper care. So yeah, I think that's definitely a huge cultural barrier that comes in within Malaysia. I think in Australia, it's not as prevalent in terms of like that type of stigma, but you do get, you know, we do have communities that practice like FGM here and cutting. So I think it can be really, really challenging for doctors who don't have training in like cultural competency and like using the right language to not make people that come in who have been through these practices, you know, to feel shamed and uncomfortable being there. You know, it is something that's quite difficult that, you know, they may not understand the gravity of what they've gone through. So I think, yeah, it's definite, like cultural barriers play a huge role. I could go on and on about it, but yeah, I think that's, I guess, things that I've experienced in Malaysia. I remember once I went for a doctor's appointment as a like young adult. I think I was 19 back home visiting my family, and I went to the nurse and my mom was with me and she was just waiting outside, and then the nurse comes to ask me, you know, all the typical questions, and then she like comes down into a little whisper and she's like, are you sexually active? And I was like, I'm like, okay, it's not that embarrassing, but I'm like, yes. So yeah, you can definitely, you know, see little things like that definitely, you know, even if you as a patient don't really feel any stigma like or judgment on what your choices are, when you have interactions like that, you're just like, should I be ashamed? Is this something I should be uncomfortable with? Yeah.
Yeah, I'd only really add to that, Natasha, but that sounds like a really difficult, not difficult necessarily, but I think bizarre experience when it's the medical professional kind of almost re-stigmatizing or emphasizing that stigma. That's really difficult. I think that in the research, in some of the kind of conversations we had with healthcare professionals, it's really interesting because it was like the sense that it wasn't necessarily that I guess like service providers and sexual health experts it wasn't that they didn't want to kind of learn more and try to kind of become more kind of culturally like competent and sensitive. It was more just that kind of worry and anxiety around saying the right thing or just not having that training to begin with. And so that I think one of the recommendations and something that a lot of kind of more specialist services, so by and for services, really would kind of emphasize is that cultural competence training needs to kind of be embedded throughout a kind of a professional sort of career. So it's not like a kind of a tick box thing where you have it once and then that's sort of left. It's like it needs to be a kind of evolving and continuous kind of process. And I think just ensuring that the professionals do have that kind of regular support is really important. And I think maybe another thing to say would just be around providing healthcare professionals with more of an understanding of like how kind of cultural sexual health stigma and discrimination intersects with other kind of issues. So like HIV in particular, we were sort of hearing from residents who were HIV positive and really had kind of struggled with their kind of communication and like experiences in services, and actually there was kind of some really sort of shocking cases where you had kind of individual who was HIV positive kind of going to the clinic and actually experiencing a lot of discrimination and just like a lack of education. So I think it's like maybe from a cultural competency perspective, it's about ensuring that the professionals have that support, and that's like throughout, it's consistent, but also that stigma and shame that's embedded within kind of on an individual professional level is tackled, and that we really do emphasize that it's not okay, and ensure that like that this is a practice that is kind of stamped out. But yeah, I think it's there's a lot to unpack and a lot to say, but I think those are maybe two kind of key things that came out from the research.
Thank you so much for your answers. Yeah, I just want to, I can add a little, something that I have heard, like basically CAWI right now, we're working on a sexual health sort of education. We're doing like a sexual health education study. Like it's a grassroots study. We're looking at like immigrant women's experience with sexual health. And something that I've heard echoed a lot is that feeling of like being sort of like, because we all each have different culturally influenced explanatory frameworks for like what we're experiencing and how we describe those things. Sometimes people with different, frameworks will go into the healthcare system, and then they'll try to explain what they're experiencing, and they'll just feel really like patronized, and they'll feel like, what they are experiencing, it's like looked down on and seen as like almost, like primitive, like there are experiences like that can make it really discouraging to seek out care again. So yeah, but thank you so much for bringing up those points. And we have a question through Menti. So what role do you think pharmacare has? And for Layla, particularly in your experience with the HIV community in South London, how do you feel like that role plays out?
Yeah, I think that's a really interesting question. I think that the main thing that I would be able to sort of like reference here is the new availability of PrEP, and then maybe that's where the question is, the context kind of comes from. So PrEP as a medicine has the potential to kind of prevent and kind of manage kind of HIV, and in terms of the prevention sort of side of things, it's now become a kind of a free medicine on the NHS, and anyone and everyone can access it. So I think that has the potential to really transform HIV stigma and really support kind of different communities and individuals to feel a lot more secure in in conversations around HIV, but also empower kind of people living with HIV to be able to navigate kind of sexual relationships with less stigma as well, and just that kind of peace of mind. But I think what we've seen is with that kind of the emergence of that as a free and available medicine has also kind of come with its own inequities. So there's been like a really big and successful kind of PrEP promotion campaign that was really targeted at the kind of I guess gay community in London, and that's been rolled out, and it's very well evidenced, and lots of good kind of wins have happened with that. But I guess with HIV transmission now, kind of the largest, kind of the biggest source of transmission now coming within heterosexual relationships, and those kind of concerning data points around kind of Black African women, for example, facing like late diagnoses. Like, we do really need to communicate that PrEP is for everyone, and PrEP is for women as well. And some organisations like Prepster, which I can share the link to, have been really like spearheading PrEP for women promotion campaigns, and that's, I think, really really great. But because it's such a new thing, newly available on the NHS, I think it's going to take some time before that there's that kind of like wider understanding of like what it is as a medicine, who should take it, when it's relevant, and basically sorts of, it will take some time, I think, before we see the positive impacts of that on kind of HIV stigma. But it's still like a really positive and exciting kind of opportunity. And I don't know whether there's if that kind of person has any, if that kind of answers that question around like pharmacare. In terms of other medicines, I think I'm maybe not best placed to answer that question, but PrEP as a thing has been like a really a really important development in kind of HIV prevention in the UK.
Yeah, I don't know, Natasha, if you had anything to add? No, okay, totally fine. So another question we have is, often when we're talking about healthcare, we tend to discuss physical health, but what barriers to achieving good mental health, emotional health, and spiritual health among immigrants and refugees have you witnessed or are you aware of? And how do you think sexual health might factor into this?
Oh my gosh, where do I even begin? I think as someone that's studying like counseling right now and who is starting to become a mental health practitioner, and someone who has been through and is going through therapy within the Australian system, there is so much that I think that like mental health practitioners here can do to improve how they are when they interact with people from immigrant backgrounds, people of color. I think, like Leila said, I think it's not that they, don't want to learn. It's not that they like are resistant to it. I think it's just whether or not they're given this cultural competency training. And I think it's also, again, just coming back to what I said, listening to the people that, you interact with, they're listening to the patients. I think it can be really, really frustrating when you're trying to access mental health care and, for example, you're talking about the difficulties of the dynamics between you and your family, only to have a therapist who is, white and Australian and, tell you things that may not apply to your family. For example, if you come from an Indian family like mine and, you get a therapist saying like, just cut them off, like that might be better for your mental health. Sometimes you can't. What people really need in that is, strategies and tools to be able to manage their own mental health while not having to, sacrifice those relationships. And whether that's, creating their own boundaries for themselves, but it's just being able to understand that, and that not everyone is going to be able to, like, you can't apply the same tools to every single person. Everyone's going to have their unique background, their unique lives. And as mental health professionals, it's our responsibility to be able to adjust to all of that.
Yeah, it's really interesting, Natasha. I think maybe I would, just kind of echo what you're saying and maybe just add, I think there's such like a benefit and importance of like a holistic kind of healthcare system, social care system that like really thinks about all of these aspects of our kind of well-being as like interconnected. And I think I've seen it done really well at the organization I used to work at before I was at Shape History. It was a kind of a small Middle Eastern women's kind of domestic violence charity. But one of the things they used to do was like, you'd have like the kind of weekly, like you'd have like a counselling service that was like one-on-one, but then also like weekly sessions that were more like a kind of, like a small group sessions that were like a safe space and really provided that space for women to speak about anything, I guess, ranging from their kind of, relationship issues, mental health, like religion, community, anything that's important to them, but in that kind of like holistic setting. And I think if services could kind of integrate some of that that approach that I think some of these smaller community groups do really well, then I think that could really well support kind of migrant and refugee kind of women better in a way that actually feels like relevant and not like kind of like paternalistic, like some of the advice you guys are referencing. So I think yeah, it'd be nice to see more of that like holistic approach. And that's just me speaking kind of like on a personal level, because I do think, you know, it's amazing having like a national health service, and that you know, that we do have access to, you know, free testing, treatment, all of the basic things. But I think that you do have to end up seeking that more like mental, spiritual, kind of emotional support, often through like disparate ways and places, and often like, you know, I guess particularly like mental health support is not great, at least in the UK, for in the NHS. So I think, yeah, we do need, it'd be nice to move towards like a system that supports people in a more holistic way.
Thank you so much for your answers. So we have a question in the chat from Victoria, and they're asking, what educational programs, resources, or books have been the most impactful to improving your work as a healthcare provider regarding culturally competent, intersectional, feminist, and holistic sexual health?
I can go first. My answer will be quite brief. I think for me, what has been the most impactful, as you know, someone that talks about sex positivity on my platform, has definitely been following creators that are diverse. You know, following creators whose experiences I, you know, can't personally understand, because I am a South Asian, Malaysian young like women, and you know, that might not be the case. I can't speak on experiences that I don't have, and I think I love listening to people who have different experiences to I do, you know, people who are young and Black and Muslim. And because, you know, Malaysia is such, like, we have such a huge Malay Muslim population, and that's like obviously a huge part that I have no experience with as someone who is not Muslim. But because that's the audience that I talk to, I always love to listen to Muslim creators that talk about sexual health, and actually point Malaysian Muslims to that, to those creators, because I think they're a community that really doesn't get, especially in Malaysia, a lot of people talking about what it means to care for their sexual health, and whether that's by themselves, in their relationships, and you know, as a like whole holistic thing. So I think, yeah, those creators have been really, really helpful to me. Just, yeah, for me, it's just definitely been following creators that are diverse, and that allows me to have a more intersectional view when it comes to talking about sexual health and understanding it as well. And yeah, just books. I don't know of any books, and I'd love to hear if anyone has recommendations, because I'm always looking for new books to read. But I think a book that sort of changed my perspective on sexual health and just understanding my own as someone, like as a person with a vulva, has definitely been Come As You Are by Emily Nagoski. So if anyone hasn't read that, I would highly recommend reading it. Definitely talks heaps about a lot of the myths that we grow up hearing about our bodies, and dispelling all of that as well. It will blow your mind. Yeah, that's it.
Thanks for sharing, Tasha. Definitely, I don't think I've heard of that one before, but I will definitely check that one out. I think for me, it's probably been really similar, like from a kind of online content creator perspective. I mentioned a few examples, but I think just, yeah, like mostly Black-led initiatives, especially like within the partnership. Obviously, we have two Black-led organisations, but Shape History and Brook, obviously being not kind of being a Black-led organisations. I think it was really important for us to really take the time to kind of to listen and to kind of read and research kind of all the kind of amazing different kind of content creators and kind of sexual health doctors that are out there and leading really important work, and making sure that they're, like, we were like referencing and citing that. So I think Decolonizing Contraception as a collective based in the UK are really amazing as well. So Dr. Annabelle Soomimo is kind of the founder and kind of leader, and you can find many of her kind of videos online. And there was another book that came out this year called The Sex Lives of African Women. So that was published in the UK, and we've, kind of within the partnership have been able to read that, and it's a great one. I'll share the link to that in the chat as well. I think there is like a bit of a lack of really, there's not like tons of published kind of research on this topic, at least on like a local level. And I think that's something that is a shame, but I think there are lots of amazing kind of sex positive books and literature out there. I will have a think and I'll see if there's anything else I can share, but I think that book in particular, Decolonizing Contraception, Praxter as initiatives, and some of those like emerging kind of researchers as well, that I kind of mentioned earlier in the talk.
Thank you so much for sharing. Yeah, so I think those are all our questions for today. So I'll invite Tori now to, do a bit of a conclusion for our event and thank all of you.
Yeah, thank you, everybody. This has been such an engaging discussion, and I'm so happy we were able to host this today. I want to give the biggest thank you to our speakers for sharing their stories and experiences. It's been really interesting to hear the different perspectives across different regions in the world and different backgrounds. I also want to give a huge shout out to Crystal and Selma, our amazing co-hosts, who did a fantastic job. And yeah, we'd really encourage you all to check out CAWI's amazing work, as well as Medical Herstory. We'll link our social medias in the chat so you can find out more about us. We have amazing initiatives coming up, like patient advocacy workshops, where you can learn more about how you can advocate for yourself in healthcare settings. And also things targeted at healthcare professionals to undo some of those biases we talked about earlier, and increase inclusion for all. So the biggest thank you to everybody for attending today's event, and we hope that you took something away from it. We would love, as you are saying your goodbyes, if there's any key takeaways you want to drop in the chat. I know I was moved today a lot by centering patients as being the experts of their own lived experience, which is such an important point, and really thinking thoughtfully in a nuanced way about what cultural competence looks like in different settings. So thank you again so much, everybody, and we hope you have a great rest of your day. Take care.